Hello to everybody. It's a great pleasure to be here. I am Davide Chiumello from the University of Milan, and I will give a talk regarding lung imaging, CT scan, and lung ultrasound in COVID-19 patient. Here, in the first slide, is reported a different definition on acute respiratory distress syndrome. The last definition was released a few years ago, and clear divide different level of impairment of oxygenation from mild, moderate to severe according to the PO2-FO2 ratio. The moderate and severe form are characterized by PO2-FO2 ratio lower than 200. It requires minimum level of 5 of PEEP. And how can we diagnose ARDS patient? In very simple way, by performing a chest X-ray, and chest X-ray is characterized by the presence of bilateral infiltrates. And there is no mention regarding the presence of heart failure. But it is also suggested to use CT scan in order to improve the characterization of the opacity, the amount of the disease, and to stratify the severity of the disease. Regarding patients with COVID-19 ARDS, indicators of severe disease are the presence of high respiratory rate, usually higher than 25, 30 breaths per minute, severe hypoxemia, and the presence of lung infiltrate that usually have a 50% higher of the lung file involved. This is a typical chest rate of not COVID ARDS, and as it is clearly shown, is the presence of the bilateral disease with the minimum amount of pleural effusion and the patchy and diffuse distribution of the lesion. This is the same patient underwent a CT scan, and what is clearly shown in this slide is the different distribution of the disease and the different amount of consolidation in the upper part of the lung are characterized by the presence of quite normal lung. Then we have the white part of the lung that are typical consolidation or atelectasis. Then there is a different amount of interstitial disease and the minimum amount of pleural effusion. What is present in COVID-19 ARDS is a completely different picture. Starting from the upper left part is a patient with a minimum amount of the disease, minimum amount of the interstitial lesion present in the right and the left part of the lung. In the right part, in the upper panel, is another patient with a higher amount of the interstitial disease that is distributed in the lower and the middle part of the lung. Then we have a patient with a huge amount of consolidation, the minimal presence of interstitial disease. And at the end, we have a severe patient with consolidation and interstitial disease, but barotrauma. There is a huge amount of pneumomediastinum and subcutaneous emphysema. But what we have learned from lung CT scan is that we can have at the beginning a patient with a severe hypoxemia with a PO2-FO2 ratio lower than 100, so a typical ARDS characterized as severe ARDS according to the level of hypoxemia, but on the contrary with a minimum amount and extension of the disease. The same patient after 7 days present the same level of hypoxemia, some same severities according to the previous ARDS classification, but a completely different picture. There is a huge amount of consolidation localized in the lower and the middle part of the lung. So how is possible to have same level of hypoxemia with a very different picture and amount of the disease? By a quantitative analysis, by applying lung CT scan, in the blue are the present and the amount of normal lung areas, and in the red are the presence of consolidation atelectasis. So in the first case, we have a patient with a severe hypoxemia, but a quite normal lung parenchyma. On the contrary, the same patient, same severity of hypoxemia, but with a huge amount of consolidation. So the only explanation to have the same amount of hypoxemia in this patient is a ventilation perfusion alteration, while on this patient is the presence of typical ARDS with a huge amount of shunt. By performing CT scan in 3 groups of patients, COVID-19, ARDS in the middle, ARDS patient matched for the same severity of hypoxemia, and another group of ARDS patient matched for the same lung mechanics. So the 3 groups of patients present a similar lung weight. The lung gas volume was significant reduction in patient with ARDS, matched with the same severity of hypoxemia. And looking at the amount of not aerated tissue, so amount of consolidation and atelectasis, was significantly higher in patient with ARDS compared patient with COVID-19 ARDS. Similar results were also found by another group. This was a multi-center observational study in which 300 patients underwent lung CT scan, and it was measured the mechanical characteristic. The red point are patients with COVID-19 ARDS, and this group of patients presented better compliance compared to classical ARDS, but they present a similar lung weight compared to the classical ARDS. Another useful application of lung CT scan is to perform a quantitative analysis to have an idea regarding the amount of the lung consolidated or compromised. This was a patient admitted in the emergency department, and here in the blue is the amount of the normal lung parenchyma, in yellow the lung compromised. So in this patient, the amount of the disease was quite low. On the contrary, we have another patient with COVID-19 ARDS present a significant high amount of lung disease that can reach around 40-50%. So by applying the quantitative analysis, it's possible to predict, according to the amount of the disease, the possible requirement of oxygen support, such as non-invasive ventilation, high flow nasal cannula, and also it's possible to predict the need of intubation and mechanical ventilation. Regarding the consensus statement released from the Flight Society, that was a working group by radiology, by intensivity, they released this flowchart. So a patient admitted with COVID-19 who presented typical sign of respiratory distress, we have to perform the imaging. And also we have to repeat the imaging as a way the monitor every time we have a worsening of respiratory status. Then we have to evaluate a patient with COVID-19, and not only, but also in ARDS patient, the difference between recruitment and inflation. And CT scan is very useful to analyze and to describe the amount of recruitment. Recruitment can be defined in several ways. I apply this definition is the aeration of previous gasless lung regions, while inflation is just the further aeration of already inflated, so already open lung region. What we have learned in a ARDS patient that the amount of recruitment by increasing PEEP was quite low. In this study, the median of lung recruitment was around 10%. This is distribution according to the amount of potential recruitable lung. And he's in the upper part is a patient with a low amount of lung that can be recruited. In the lower part is a patient with a high amount of recruitment. Why? Because the white part that are consolidation and atelectasis are inflated by increasing the level of PEEP. What was found in COVID-19 ARDS by performing a lung CT scan at 2 level of PEEP, the amount of recruitment was quite low, was around 5% of the total lung weight. And here is the distribution of the amount of recruitment in the whole population. By dividing patient in not recruitment and recruitment, evaluated 2 different levels of PEEP, it was found any significant different level regarding the total lung weight. The lung gas volume was similar. What was different was the amount of notary tissue that was significantly higher in the recruitment group. And by increasing PEEP, it was observed a similar behavior in the 2 groups. By moving from the application of lung CT scan, we can also use lung ultrasound. Lung ultrasound is used as in ARDS patient according to the lung ultrasound score from 0, which is present when we have a lung without disease, by moving from a score to 1 to 2, according to the present the amount of the interstitial disease that is visualized as B line, and the score 3 is the presence of lung consolidation. So here is the difference in patient with ARDS compared to patient with COVID-19 ARDS. Usually patient with ARDS present a B-line confluent, and according to the amount of the B-line, we have a complete white lung. And usually we don't have any base apex gradient, and also we can have a patch distribution of consolidation. Usually COVID-19 ARDS patient present a different amount of the B-line that can be also generate a white lung. Usually they have a peripheral patchy distribution and the presence of pleural irregularity and also the presence of consolidation. This is a flow chart that can be suggested according to the severity of the patient admitted in emergency department. So a patient admitted with a life-threatening disease in the red color, we have to apply a very simple lung ultrasound score to evaluate a possible requirement of non-invasive ventilation or endotracheal intubation. On the contrary, patient without an emergent situation, so in an urgent situation, we can apply a chest X-ray, lung ultrasound, or lung CT scan according to the severity of the disease. This was a very recent study that was released in the Intensive Care Journal. This was a suggestion according to the use of lung ultrasound and the amount of the B lines. So if you have a patient without B lines and with the rest of the chest is normal, this patient probably has a low probability that can have a COVID-19 pneumonia. On the contrary, if this patient without B-lines, but can have a consolidation of pleural effusion, can have an intermediate picture, intermediate probability to have COVID-19, while patient can present a multiple B-line with a white lung or irregular pleural line. This can be characterized with a good accuracy with the presence of high COVID-19 pneumonia. This is the same patient underwent lung CT scan and lung ultrasound. And as you can see, there is a patchy distribution of the disease with a clear difference in the lung ultrasound. This normal lung region, completely black, and here there is a normal lung ultrasound score. There is very few amount of the B-line and with a normal pleural line. On the contrary, in the presence of interstitial disease is characterized by the presence of multiple B-line that can generate a white lung according to the severity of the disease. So, try to summarize my talk. It is possible to apply ultrasound as in the emergency department or as a diagnostic tool for COVID-19. However, at the present time, there is a limited experience. On the contrary, CT scan is more sensitive for the early parenchymal lung disease detection, to detect a possible disease progression, and also to evaluate a possible diagnosis include, for example, heart failure, a possible presence of pulmonary thromboembolism. So what we can conclude, we can apply lung ultrasound or lung CT scan to evaluate the lung morphology. Lung CT scan is able to predict the outcome, the need of oxygen support, the need of intubation and mechanical ventilation. CT scan is a useful tool to evaluate and to compute lung recruitment. And if you have to apply lung ultrasound, we have to use a standardized protocol based on the score from 0 to 3. Thank you very much for your attention.